So we've talked a lot about the cardiovascular risk factors and their relationship to cognitive decline and to overt dementia. Well, can we do anything about it? And some studies suggest we can, particularly in terms of blood pressure lowering. These are old studies, but basically the sister study and the progress study showed that blood pressure reduction decreased the risk of developing dementia. But this was not a universal finding. Now, be mindful of the fact that these patients varied in age, and it would appear that the SCOPE study, where they were already elderly, age 70 to 89, did not show a significant difference. And the types of medications used to treat blood pressure were also variable across the studies. Moreover, these studies had variable follow up periods that were short, somewhere between 2 and 4 years. So, in addition to different antihypertensive drug classes such as ACE inhibitors, angiotensin II receptor blockers, diuretics, and calcium channel blockers, which may be more beneficial in reducing dementia, there are other factors as well, such as patient age, duration of follow up, and other characteristics of the cohort. Nonetheless, those patients had marked blood pressure elevations, and many patients, as we've shown in late life, already have started to experience dramatic declines in blood pressure that is both age related but accelerated or exaggerated in the setting of dementia. So the specific treatment plans with regard to blood pressure control and targets of blood pressure control have not been worked out for patients who are free of dementia, those with mild cognitive dysfunction, and those with overt dementia. What about diet? Well, multiple diets have been shown to improve cognitive function, and those basically include those that are glycemic poor, such as the Mediterranean diet. In this study of 334 cognitively healthy adults, median age of 67 years, they were randomized to three different types of Mediterranean diets. There was a control group. The median follow up was 4.1 years, and this study was conducted in Barcelona, Spain. And while there were no between group differences observed at baseline, the Mediterranean diet supplemented with olive oil or nuts was associated with an improved composite measure of cognitive function. And several other studies support this notion as well. And perhaps even more robust than a Mediterranean diet is that of exercise. Exercise portends not only anatomic benefits, but multiple studies have shown that regular exercise, such as walking, can markedly enhance cognitive function and retard cognitive impairment. What is the mechanism of benefit? Unclear, but multiple inflammatory, oxidative, and even stress hormone related mechanisms have been suggested. So we've been practicing for the last 20 years in the era of cardiovascular risk reduction. And many patients are indeed treated. They're treated with blood pressure lowering agents. They're treated with statin drugs. They're treated with aspirin and other medications for vascular disease, irrespective of whether they have vascular dementia or Alzheimer's disease or the mixed type, which all account for 90% of cases. And as compared to 30 years ago, there's been a 44% lower chance of a 60-year-old developing dementia than there used to be. And moreover, the mean age at dementia onset has increased from 80 to 82 to 84, and more recently to 85 years of age. This is a slide I showed before, showing that vascular risk factors were associated with tau deposition. And that was in patients who were not treated with disease, but risk factors such as total cholesterol, LDL cholesterol, systolic and pulse pressure, and the Framingham risk score for cardiovascular disease was associated with tau in patients who were not treated with cardiovascular risk reducing medications, but these associations were blunted and not significant in those who were treated with meds. So, a bit of optimism. So, how can we summarize the treatment of such patients? And the answer is exercise and a Mediterranean diet, hopefully for all, as hard as that is. And I recognize that regular aerobic exercise and a judicious diet may be difficult in late life. Aggressive treatment of blood pressure and obesity and hypolipidemia, particularly in midlife, but we shouldn't overtreat in late life. And the data is showing lower blood pressures and lower body mass index and lower cholesterol levels associated with dementia in late life would urge us to proceed with a word of caution. In Alzheimer's disease, donepezil shows mild benefit, slows the progression, and, as I mentioned before, less tight blood pressure control might be better in these patients. With regard to vascular disease, risk factor modification is more straightforward. We're not only doing it to prevent the progression of dementia, but also to reduce cardiovascular and cerebrovascular events. And acetylcholinesterase inhibitors may have mild to moderate benefit, but in patients with vascular disease, patients are more likely to experience side effects and are more likely to discontinue the drug. There may be a role for antiplatelet agents and anticoagulation in patients with vascular dementia, particularly in those with atrial fibrillation and possibly congestive heart failure, and even a role for antidepressants, which patients with cardiovascular disease often take because somewhere between 30 to 50% have overt symptoms of depression as well. In summary, cardiovascular risk factors contribute to the development and progression of most forms of dementia, irrespective of whether primarily neurodegenerative or vascular. Converging evidence that the pathophysiologic processes of Alzheimer's disease begins years and perhaps even more than a decade prior to the diagnosis of dementia, so that there is a long preclinical window of opportunity of Alzheimer's disease. And this is a wonderful opportunity for potential intervention with disease-modifying therapy. Cardiovascular risk factors such as hypertension and obesity during midlife are most predictive, as there are differential changes during the prodromal phase. And with regard to blood pressure elevation, patients with dementia have more rapid rises, but more rapid declines during symptomatic dementia. Moreover, there appears to be a unique trajectory phenotype that precedes cognitive impairment, characterized by more rapid falls in blood pressure, more rapid falls in weight loss, and more rapid falls in cholesterol. And some literature suggests that there's also worsening of glycemic control. Tighter blood pressure control during midlife carries the potential to prevent or delay dementia, whereas less aggressive blood pressure control and lowering therapy might be indicated in latter stages. Concerns regarding dementia could be a motivating factor in helping patients to engage in healthy behaviors and cardiovascular risk reduction. As multiple studies have shown, dementia is a primary concern of patients, in many studies, even more so than death itself. Also, dementia may negatively impact adherence to other medications, and therefore I would contend that dementia is a cardiovascular, or what I like to call a vasculocardiac disorder. Why vasculocardiac? Well, most cardiac disease has a vascular component. And in fact, it's pretty hard to find a form of heart disease that does not have abnormal vasculature. suggesting that cardiovascular could be renamed vasculocardiac. Getting back to our patient, she had elevated LDL levels. That may be an opportunity. Her blood pressure seemed to be at target, so I would not lower her blood pressure further. In fact, one could make the argument to let up a little bit on her blood pressure medications and let her blood pressure rise to the higher limits of normal as well. So I hope over the last 40 minutes or so that I've convinced the group that dementia is indeed a vascular disorder, irrespective of the cause. Thank you.